Hi everyone, my name is Yanni Thompson. I'm going to be presenting on albuterol. So first we're going to the drug classification, generic and brand names. So the first brand name for albuterol would be Proventil HFA and Ventolin HFA. The generic name would be albuterol sulfate. And the classification would be a bronchodilator, as well as the therapeutic class being a bronchodilator as well. The pharmacologic class would be an algeric, as well as albuterol being known as salbutamol. As for the indications for use of albuterol, it's used as a bronchodilator to control and prevent reversible airway obstruction, usually caused by asthma or COPD. If it's used as an inhalant, it's used as a quick relief for acute bronchospasms and for prevention of exercise-induced bronchospasms as well. If this medication is being taken by mouth or PO, it's used as a long-term control agent in patients with chronic or persistent bronchospasms. Okay, as for the method of action, it is a selective beta-2 agonist that stimulates the adrenergic receptors of the sympathomimetic nervous system, which results in smooth muscle relaxation in the bronchial tree and the peripheral vasculature. So essentially what it's doing is it's working by relaxing the smooth muscles of the airways, which then activates the beta-2 adrenergic receptors in the lungs, and this results in the bronchodilation. As for the common dosage and route, for children 12 years old or older, if they're taking this medication by mouth, it is usually 2 to 4 milligrams, 3 to 4 times a day, or 4 to 8 milligrams of extended release tablets twice a day. For geriatric individuals who's taking this medication by mouth, the dose should not exceed 2 milligrams and should be taken 3 to 4 times a day. For inhalants, for adults and children older than 4 years old, or taking an MDI or a dry powder inhaler, it should be with 2 inhalants every 4 to 6 hours or 2 inhalations 15 minutes before exercise. As for the pharmacokinetics of albuterol, the route, which would be inhalation, the onset of action, which would be immediate, the peak plasma concentration, which is 10 to 25 minutes, and the elimination half-life, which would be 3 to 4 hours, as well as the duration of action being 3 to 4 hours as well. Albuterol is metabolized in the GI tract, presumably by the sulfotransferase. The primary route of elimination of albuterol is through the renal excretion, which is 80 to 100% of either the parent compound or the primary. So, as for the adverse effects, patients can experience nervousness, shakiness, headache, throat or nasal irritation, muscle aches, tachycardia or rapid heartbeat, palpitations, chest pains, and hives or rashes. For the interactions that are involved with albuterol, beta blockers. So beta blockers tend to block the effects that albuterol has on the individual's breathing. So this can cause severe bronchospasms and more trouble breathing in people with asthma. Diuretics or water pills can have an interaction with albuterol as well. It can cause heart rhythm changes and potassium levels that drop lower than normal. So Lasix would be an example of that. Digoxin also interacts with albuterol, and it can lower the digoxin levels in the body and cause the drug not to work as well. As for nursing considerations, nurses need to monitor signs of paradoxical bronchospasms such as wheezing, coughing, difficulty breathing or dyspnea, and tightness in the patient's chest. They also need to assess the blood pressure regularly and compare to normal values or the baseline of the patient. They also need to assess heart rate, ECG, and heart sounds, especially during exercise. They need to monitor and report any signs of the central nervous system toxicity, including nervousness, restlessness, tremors, or hyperactivity. They need to monitor and report any muscle weaknesses, aches, or cramps that might indicate low potassium levels. And lastly, they need to monitor signs of hyperglycemia, including drowsiness, fruity breath, increased urination, and unusual thirst. As for the NCLEX question, all of the following are examples of adrenergic agonists except which one of these medications would not be considered an adrenergic agonist? So the answer to this would be D, tiotropium, which is actually an anticholinergic bronchodilator, as well as its trade name being Spiriva. My references.